Today, we will be discussing one of the most widely diagnosed cancer for women worldwide, which is breast cancer. For today's topic, we have the following outline. First, we'll start with a brief introduction about breast cancer, its epidemiology, and risk factors associated with it. Second, we'll talk about its pathophysiology, the different types of breast cancer, what causes it, its symptoms and complications associated with breast cancer. Third, we'll be talking about how breast cancer is diagnosed. And lastly, the available treatments for breast cancer, which includes both local and systemic treatments. So, without further ado, let's begin. Breast cancer is a disease in which cells in the breast grow out of control. There are different kinds of breast cancer, and the kind of breast cancer depends on which cell in the breast turn into cancer. Breast cancer can occur in both men and women, but it's far more common in women. Less than 1% of all breast cancer diagnoses are for men. Despite advances in diagnosis of breast cancer, it can still go undetected simply because at its early stages, patients often feel no pain or discomfort until they have invaded nearby tissues, leading to late-stage diagnosis. Breast cancer is the second most common type of cancer diagnosed worldwide, next to lung cancer. About 2.1 million of all new cancer cases were breast cancer in 2018. Every year, an average of 1.3 million women are diagnosed worldwide. Breast cancer currently affects more than 3.1 million women in the US alone. Every 3 minutes, a woman is diagnosed with breast cancer in the US. 85% of breast cancer occurs in women who have no family history of the illness, and is currently the fifth leading cause of cancer death worldwide. It has been reported to have caused 627,000 of all cancer deaths in 2018. The Philippines is among the countries in Asia with the highest number of breast cancer cases, wherein 1 in every 13 Filipino women is at risk for developing breast cancer, and 3 out of 10 Filipinas develop breast cancer before reaching the age of 75. And in 2018, 24,798 new cases of breast cancer were reported in the Philippines. Breast cancer has the highest mortality rate among 15 Asian countries, including the Philippines, wherein the 5-year survival rate is 58.6%. In 2018, it has been reported that 8,057 Filipinos have died due to breast cancer, making it the third leading cause of cancer death in the Philippines. Based on the 2018 GloboCan Philippine Cancer Statistics, there is a 1 out of 100 chance that a Filipina will die due to breast cancer before reaching 75 years of age. Breast cancer ranks first as the most widely diagnosed cancer in the Philippines. That excludes non-melanoma skin cancer for both sexes. And 31.4% of all cancer in women is due to breast cancer. Studies have shown that the risk for breast cancer is due to a combination of factors. The main factors that influence the risk for getting breast cancer includes being a woman and getting older. Most breast cancers are found in women who are 50 years old or older. The following are some common risk factors for breast cancer, which includes family history of breast cancer, gene mutation, late childbearing, early menstruation and late menopause or being obese, increased breast density, prolonged use of oral contraceptive pills, the use of hormonal replacement therapy after menopause, and alcohol intake or use of tobacco. Some women will get breast cancer even without any other risk factors that they know of. Having a risk factor does not mean you will get the disease, and not all risk factors have the same effect. Most women have some risk factors, but most women do not get breast cancer. To better understand breast cancer, let's first discuss the anatomy of the breast, followed by its pathophysiology. The breast is the tissue overlying the chest muscles, what we also know as the pectoral muscles. Women's breasts are made of specialized tissues that produce milk, which we call the glandular tissues, as well as a fatty tissue. It is mainly divided into 3 main parts. The glandular tissue is the milk-producing part of the breast. It is organized into 15 to 20 sections called lobules. Within each lobules are smaller structures called alveoli, where milk is produced. The alveoli is composed of a basement membrane which is largely made up of collagen, the alveolar cells which secretes milk into the lumen, and the myoepithelial cells, which wraps around the alveolar cells to squeeze and push milk out of the lumen, down to the lactiferous ducts, and out of the nipples. Now, surrounding the glandular tissue is the stroma, which is mostly composed of adipose tissues. This makes the majority of the breast. Connective tissues and ligaments called Cooper's ligaments run through the stroma and provide support to the breast and give it its shape. Nerves provide sensation to the breast. The breast also contains blood vessels, lymph vessels, and lymph nodes. The lymphatic vessels drain the lymph, which is a fluid containing cellular waste product and white blood cells. These lymphatic vessels mainly drain into the lymph nodes in the axilla, or what we call the armpit. Cells of the glandular tissues have receptors for certain hormones like estrogen and progesterone, which is produced by the ovaries, and prolactin, which is produced by the pituitary gland. These hormones stimulate the alveolar cells to divide and increase in number, resulting to the enlargement of the lobules. Without these hormones, the glandular cells cannot survive and they undergo apoptosis. During a menstrual cycle, there is an increase in secretion of estrogen and progesterone from the ovaries, leading to an increase in number of alveolar cells. And right after menstruation, the hormone secretions decrease, causing some of the cells to die. As a result, every menstrual cycle, the alveolar cells undergo division and apoptosis. Each time a cell divides, there is a chance that a genetic mutation can occur, and a mutation can most often lead to a tumor formation. As the affected cell, which is commonly the epithelial cells that lines the ducts of the lobules, begin to grow and replicate out of control, they start to form a tumor. This tumor, also known as an in situ carcinoma, is initially localized at the basement membrane of the alveoli. So with more menstrual cycle, there is an increased risk for tumor formation. That's why there is an increased risk for breast cancer with things that increases the number of menstrual cycle, such as early age of menarche, which is the first menstrual bleeding, and late age of menopause. Similarly, medications containing estrogen also increase the risk for breast cancer. There are environmental factors such as exposure to ionizing radiation, which causes mutation. On the other hand, things that are associated with a decreased risk for having breast cancer would include early pregnancy and longer time of breastfeeding. Breast cancer has also been linked to mutations in specific tumor suppressor genes, such as the breast cancer gene BRCA1, BRCA2, and TP53, which slows down cell divisions or makes cells undergo apoptosis when they divide uncontrollably. Mutations in both BRCA1 and 2 are autosomal dominant mutations, which can be inherited and cause familial breast cancer. In addition to breast cancer, they can also increase the risk of having ovarian cancer. In males, breast cancer is usually caused by inherited mutations in the BRCA1 and 2 genes. Some breast cancers have also been linked to mutations in the ERBB2 gene that increases human epidermal growth factor receptor 2, or what we call the HER2, which when activated, promotes the growth of cells. Once mutation occurs, a tumor may form. This tumor, also known as in situ carcinoma, has two types. The first type is called ductal carcinoma in situ. DCIS is where the tumor cells grow from the wall of the ducts into the lumen. If left untreated, DCIS over time can cross the basement membrane and become invasive ductal carcinoma. Also, cancer cells from DCIS can migrate along the lactiferous ducts, through the pore, onto the skin over the nipple. This is called Paget's disease of the nipple. These cancer cells release a substance called mobility factor, which helps them break into and settle in between squamous epithelial cells. As the cancer cell moves into the epithelium, there is inflammation, which brings about extracellular fluid out through the breaks in the skin. This fluid then dries up and forms crust over the skin's surface. The next type is called lobular carcinoma in situ. LCIS is where a cluster of tumor cells grow within the lobules without invading the ducts, causing the alveoli to enlarge. Unlike DCIS, over time, LCIS doesn't cross the basement membrane to form invasive lobular carcinoma. LCIS got its name many years ago before it was realized that it's not a breast cancer, in the sense that it doesn't invade surrounding tissues. Just like healthy alveolar cells, some breast cancer can have hormone receptors that allow them to grow in the presence of these hormones. Based on the type of hormone receptors, Breast cancer can be divided into three major types: estrogen receptor positive and HER2 negative carcinoma, which is the most common, HER2 positive and ER positive or negative carcinoma, and lastly is ER negative and HER2 negative carcinoma. The first symptom of breast cancer usually starts as a hard, painless lump or swelling in the upper or outer part of the breast. Additionally, there may be swelling in the armpit if cancer has spread in the axillary lymph nodes. Another is dimpling or depression of the skin over the breast due to the involvement of the skin. Nipples of the breast can retract, resulting from fibrosis of the lactiferous ducts and suspensory ligaments in the breast. Once Paget's disease is involved, it could cause itching, redness, crusting, and discharge from the nipple. Other symptoms would also include swelling and pain in the breast, as well as skin irritation. Let's keep in mind that these symptoms can happen with other conditions that are not cancer. If left untreated, breast cancer can lead to complications. Tumor can invade and block the lymphatic channels, causing lymph to build up in the interstitial space. This buildup of lymph would normally cause the breast to swell, but the suspensory ligaments don't allow the skin to stretch, causing the skin to become thickened and dimpled. This is called the Poderange appearance. The tumor can invade nearby tissues such as the skin, replacing it. This causes ulceration and damage to the tissues nearby. Tumor can cause local inflammation in the surrounding tissues of the breast, causing damage to the suspensory ligament and lactiferous ducts leading to fibrosis. Lastly, the tumor can spread to other organs via the blood and lymph system, causing metastasis. The most common metastatic sites for breast cancer are the bones, lungs, brain, and liver. There are multiple ways where breast cancer can be diagnosed. Diagnosis of breast cancer usually begins with a breast exam. Your doctor will check both of your breast and lymph nodes in your armpit, feeling for any lumps or other abnormalities. Early detection of breast cancer is the key to effective treatment. A mammogram can be used to screen for breast cancer. If an abnormality is detected on a screening mammogram, your doctor may recommend a diagnostic mammogram to further evaluate that abnormality. Breast ultrasound may be used to determine whether a new breast lump is a solid mass or a fluid-filled cyst. An MRI machine uses a magnet and radio waves to create pictures of the interior of your breast. Before a breast MRI, you receive an injection of dye. Unlike other types of imaging tests, an MRI doesn't use radiation to create images. And lastly, a biopsy is the only definitive way to make a diagnosis of breast cancer. During a biopsy, your doctor uses a specialized needle to extract a core of tissue from the suspicious area. Biopsy samples are sent to the laboratory for analysis, where experts determine whether the cells are cancerous. Other tests and procedures may be used depending on your situation. With an understanding of how breast cancer works, we can now have an appreciation of how it is treated. Treatment for breast cancer can be generally categorized into two. Some treatments for breast cancer are local, meaning they treat tumor without affecting the rest of the body. It can either be surgery or radiation treatment. Most women with breast cancer will have some type of surgery to remove the tumor. Depending on the type of breast cancer and how advanced it is, the patient might need other types of treatment as well, either before or after surgery, or sometimes both. Here comes now the need to use systemic treatments. Drugs used to treat breast cancer are considered systemic therapies because they can reach cancer cells almost anywhere in the body. They can be given by mouth or put directly into the bloodstream. Depending on the type of breast cancer, different types of drug treatment might be used, which includes chemotherapy, hormone therapy, targeted therapy, and immunotherapy for breast cancer. There are two main types of surgery to remove breast cancer. Breast-conserving surgery, also called lumpectomy, quadrantectomy, partial mastectomy, or segmental mastectomy, is a surgery in which only the part of the breast containing the cancer is removed. The goal is to remove the cancer as well as some surrounding normal tissue. How much breast is removed depends on where and how big the tumor is, as well as other factors. Mastectomy is a surgery in which the entire breast is removed, including all of the breast tissue and sometimes other nearby tissues. There are several different types of mastectomies. Some women may also get a double mastectomy in which both breasts are removed. Radiation therapy is treatment with high energy rays that destroy cancer cells. Some women with breast cancer will need radiation in addition to other treatments. Radiation therapy can be used in the following situations: after breast conserving surgery, to help lower the chance that the breast cancer will come back in the same breast or nearby lymph nodes; after a mastectomy, especially if the cancer was larger than 5 centimeters, if cancer is found in many lymph nodes, or if certain surgical margins have cancer, such as the skin or muscle; if cancer has spread to other parts of the body, such as the bones or brain. The main types of radiation therapy that can be used to treat breast cancer are external beam radiation therapy and brachytherapy. External beam radiation is the most common type of radiation therapy for women with breast cancer. A machine outside the body focuses the radiation on the area affected by the cancer. Which area needs radiation depends on whether you had a mastectomy or breast conserving surgery, and whether or not the cancer has reached nearby lymph nodes. Next is brachytherapy. Brachytherapy, also known as internal radiation, is another way to deliver radiation therapy. Instead of aiming radiation beams from outside the body, a device containing radioactive seeds or pellets is placed in the breast tissue for a short time, in the area where the cancer had been removed, or what we call the tumor bed. For certain women who had breast conserving surgery, brachytherapy can be used by itself, instead of radiation to the whole breast, as a form of accelerated partial breast irradiation. Tumor size, location, and other factors may limit who can get brachytherapy. Not all women with breast cancer will need chemo, but there are several situations in which chemo may be recommended. Chemo can be given after surgery, which is often called adjuvant chemotherapy. Adjuvant chemo might be given to try to kill any cancer cells that might have been left behind or have spread but can't be seen, even on imaging tests. If these cancers were allowed to grow, they could form new tumors in other places in the body. Adjuvant chemo can lower the risk of breast cancer coming back. Another situation where chemo can be useful is before surgery, which is called neoadjuvant chemotherapy. Neoadjuvant chemo might be given to try to shrink the tumor so it can be removed with less extensive surgery. Because of this, neoadjuvant chemo is often used to treat cancers that are too big to be removed by surgery when first diagnosed, often called locally advanced cancers. Also, by giving chemo before the tumor is removed, doctors can see how the cancer responds to it. If the first set of chemo drugs doesn't work or shrink the tumor, your doctor will know that the other drugs are needed. It should also kill any cancer cells that have spread but can't be seen. Just like adjuvant chemo, neoadjuvant chemo can lower the risk of breast cancer from coming back. For certain types of breast cancer, if there are tumor cells still found at the time of surgery, also called the residual disease, you may be offered more chemotherapy after surgery to reduce the chances of the cancer coming back. For advanced breast cancer, chemo can be used as the main treatment for women whose cancer has spread outside the breast and underarm area, either when it is diagnosed or after initial treatments. The length of treatment depends on how well the chemo is working and how well you tolerate it. In most cases, chemo is most effective when combinations of drugs are used. Today, doctors use many different combinations, and it's not clear that any single combination is clearly the best. Chemo drugs often used as adjuvants and neoadjuvants are the following: anthracyclines, taxanes, 5-fluorouracil or capecitabine, cyclophosphamide, carboplatin. Most often, combinations of 2 or more of these drugs are used. And here are some chemo drugs used for breast cancer that has spread: taxanes, anthracyclines, platinum agents, vinorelbine, capecitabine, gemcitabine, ixabepilone, eribulin. Although drug combinations are often used to treat early breast cancer, advanced breast cancer more often is treated with single chemo drugs. Still, some combinations such as paclitaxel plus gemcitabine are commonly used to treat advanced breast cancer. Chemo drugs can cause side effects. These depend on the type and dose of drugs given and the length of treatment. Some of the most common possible side effects include hair loss, nail changes, mouth sores, loss of appetite or weight changes, nausea and vomiting, diarrhea, and chemo can also affect blood-forming cells of the bone marrow, which can lead to increased chance of infections from low white blood cell counts, easy bruising or bleeding from low blood platelet counts, and fatigue from low red blood cell counts and other reasons. These side effects usually go away after treatment is finished. There are often ways to lessen these side effects. For example, drugs can be given to prevent or reduce nausea and vomiting. Some types of breast cancer are affected by hormones, like estrogen and progesterone. The breast cancer cells have receptors that attach to estrogen and progesterone, which helps them grow. Treatments that stop these hormones from attaching to these receptors are called hormone or endocrine therapy. Hormone therapy can reach cancer cells almost anywhere in the body, and not just in the breast. It's recommended for women with tumors that are hormone receptor positive. It does not help women whose tumor don't have hormone receptors. We can divide the drugs used for hormone therapy into three groups, namely the selective estrogen receptor modulators, the selective estrogen receptor degrader, and lastly, the aromatase inhibitors. Here are some drugs that work by stopping estrogen from fueling breast cancer cells to grow. Tamoxifen blocks estrogen receptors on breast cancer cells. It stops estrogen from connecting to the cancer cells and telling them to grow and divide. While tamoxifen acts like an anti-estrogen in breast cancers, it acts like an estrogen in other tissues, like the uterus and bones. Because of this, it is called a selective estrogen receptor modulator. It can be used to treat women with breast cancer who have or have not gone through menopause. Toremifen is another term that works in a similar way, but it is used less often and is only approved to treat metastatic breast cancer in postmenopausal women. Another type of drug used for breast cancer is fulvestrant. It is a drug that blocks and damages estrogen receptors. It is known as a selective estrogen receptor degrader. Fulvestrant is currently approved only for use in postmenopausal women. Aromatase inhibitors are drugs that stop estrogen production. Before menopause, most estrogen is made by the ovaries. But for women whose ovaries aren't working, either due to menopause or certain treatments, a small amount of estrogen is still made in the fat tissue by an enzyme called aromatase. Aromatase inhibitors work by blocking aromatase from making estrogen. These drugs are useful in women who are past menopause, although they can also be used in premenopausal women in combination with ovarian suppression. The aromatase inhibitors seem to work about equally well in treating breast cancer, examples of which are letrozole, anastrozole, exemestane. These drugs are pills taken daily. The most common side effects associated with hormone treatment are hot flashes and or night sweats, headache, mild nausea, bone pain, vaginal dryness. As researchers learn more about changes in the cell that causes cancer, they've been able to develop new types of drugs that specifically target these changes. Targeted drugs work differently from chemotherapy drugs and often have different side effects. For drugs under this category, we can divide them into four groups of drugs. First are the targeted therapy for HER2-positive breast cancer. Second are the targeted therapy for hormone receptor-positive breast cancer. Third are the targeted therapy for women with BRCA gene mutations. And the fourth would be targeted therapy for triple-negative breast cancer. In about 1 in 5 women with breast cancer, the cancer cells have too much of a growth-promoting protein known as HER2 on their surface. These cancers, known as HER2-positive breast cancers, tend to grow and spread more aggressively. Different types of drugs have been developed that target the HER2 protein. There are 3 main groups of drugs under targeted therapy for HER2-positive breast cancer. First are the monoclonal antibodies. Monoclonal antibodies are man-made versions of immune system proteins that are designed to attach to a specific target. In this case, they attach to the HER2 protein on cancer cells, which can stop the cells from growing. Trastuzumab can be used to treat both early-stage and advanced breast cancer. This drug is often given with chemo, but it might also be used alone, especially if chemo alone has already been tried. When started before or after surgery to treat early breast cancer, this drug is usually given for 6 months to a year. For advanced breast cancer, treatment is often given for as long as the drug is helpful. Pertuzumab can be given with trastuzumab and chemo, either before or after surgery to treat early-stage breast cancer or to treat advanced breast cancer. An antibody-drug conjugate is a monoclonal antibody linked to chemotherapy drug. In this case, the anti-HER2 antibody acts like a homing signal by attaching to the HER2 protein on cancer cells, bringing the chemo directly to them. Adotrastuzumab emtansine is used by itself to treat early-stage breast cancer after surgery, provided that the chemo and trastuzumab were given before surgery and there was cancer still present at the time of surgery. Famtrastuzumab deruxtecan can be used by itself to treat breast cancer that can't be removed with surgery or that has spread to another part of the body, typically after at least 2 other anti-HER2 targeted drug therapies have been tried. HER2 is a type of protein known as a kinase. Kinases are proteins in cells that normally relay signals such as telling the cell to grow. Drugs that block kinases are called kinase inhibitors. Lapatinib is used to treat advanced breast cancer, typically along with chemo drugs, capecitabine, or with certain hormone therapy drugs. Neratinib is used to treat early-stage breast cancer after a woman has completed 1 year of trastuzumab, and it is usually given for 1 year. It can also be given along with chemo drug capecitabine to treat people with metastatic disease, typically after at least 2 other anti-HER2 targeted drugs have been tried. Tucatinib is used to treat advanced breast cancer after at least 1 other anti-HER2 targeted therapy has been tried. It is typically given along with trastuzumab and the chemo drug capecitabine. About 2 out of 3 breast cancers are hormone receptor positive, either to estrogen or progesterone. For women with these cancers, treatment with hormone therapy is often helpful. Certain targeted therapy drugs can make hormone therapy more effective. However, these targeted drugs may also add to the side effects. Under this category, we have 3 main groups. The first group is the CDK4/6 inhibitors. Palbociclib, ribociclib, and abemaciclib are drugs that blocks protein in the cell called cyclin-dependent kinases, or what we call the CDKs, particularly the CDK4 and CDK6. Blocking these proteins in hormone receptor positive breast cancer helps stop the cells from dividing. This can slow cancer growth. These drugs are approved for women with advanced hormone receptor positive HER2 negative breast cancer. Next are the mTOR inhibitors. Everolimus is a targeted drug known as an mTOR inhibitor. It blocks mTOR, a protein in cells that normally helps them grow and divide. Everolimus may also stop tumors from developing new blood vessels, which can help limit their growth. In treating breast cancer, this drug seems to help hormone therapy drugs work better. And lastly, the PI3K inhibitor. Alpelisib is a targeted drug known as a PI3K inhibitor. It blocks a form of the PI3K protein in cancer cells, which can help stop them from growing. Olarapib, talazoparib are drugs known as PARP inhibitors. PARP proteins normally help repair damaged DNA inside cells. The BRCA genes BRCA1 and BRCA2 also help repair DNA in a slightly different way, but mutations in one of these genes can stop this from happening. PRAP inhibitors work by blocking the PRAP proteins. Because tumor cells with a mutated BRCA gene already have trouble repairing damaged DNA, blocking the PARP proteins often leads to the death of these cells. In triple-negative breast cancer, the cancer cells don't have estrogen or progesterone receptors, nor do they make too much of the HER2 protein. A drug mostly used for this type of breast cancer is sacituzumab govitecan, which is an antibody drug conjugate. In this case, the monoclonal antibody part attaches to the TROP2 protein on breast cancer cells and brings the chemo directly to them. TROP2 is a protein that some breast cancer cells make too much of. TROP2 causes breast cancer cells to grow and spread quickly. The side effects of HER2 targeted drugs are often mild, but some can be serious. For most women, these effects last a short time and gets better when the drug is stopped. Some can cause severe diarrhea, hand-foot syndrome, in which the hands and feet become sore and red, and may blister and peel. Liver problems, serious lung disease, nausea and vomiting, hair loss, and the list goes on. And lastly, we have immunotherapy for breast cancer. Immunotherapy is the use of medicines to stimulate a person's own immune system to recognize and destroy cancer cells more effectively. Immunotherapy can be used to treat some types of breast cancer. An important part of the immune system is its ability to keep itself from attacking normal cells in the body. To do this, it uses checkpoints, proteins on immune cells that need to be turned on or off to start an immune response. Breast cancer cells sometimes use these checkpoints to avoid being attacked by the immune system. Drugs that target these checkpoints, known as immunotherapy drugs, help to restore the immune response against the breast cancer cells. One drug is currently used for this purpose in breast cancer, the atezolizumab. Atezolizumab targets PD-L1, a protein that is found on some tumor cells and immune cells. Blocking this protein can help boost the immune response against breast cancer cells. This can shrink some tumors or slow their growth. Side effects of atezolizumab can include fatigue, cough, nausea, loss of appetite, constipation, and diarrhea. Thank you very much for listening. I hope you learned something new about breast cancer and have gained awareness about its management. If you have questions about the topic, please feel free to ask. Thank you so much for staying with me.